Si les parece, Pablo, podemos ir autorizando al doctor Mangus para que comparta su presentación.
Can you hear me okay?
Yes, perfect, Richard. Thank you.
Let me see.
Si les parece, Pablo, podemos ir autorizando al doctor Mangus para que comparta su presentación.
Okay.
Yes, perfect, Richard.
Are you able to see my screen?
Yes, great.
Okay, so I will go ahead and start. Again, this is the same presentation I presented before. I've made just a few changes to it. So if you have questions, we can talk at the end. I'm going to speak about static preservation of abdominal organs, including a good discussion about donation after cardiac death, because we find that choice of preservation solutions may be very important in donation after cardiac death. To start out with, I'm going to give you an outline. We're going to talk about the injury that occurs in organ donation, history of static cold storage, current research in the area, and then I'm going to spend a brief amount of time on each of the abdominal organs: kidney, pancreas, islets, intestine, and most of my time will be spent on liver, and then donation after cardiac death. So this is a brief summary of the injury that occurs when a organ or the cells within the organ become ischemic. You decrease the metabolic rate, there's decreased protein synthesis, and there's no energy available, so that things such as cellular pumps for electrolytes and fluid are inactivated, so you end up with cell swelling. The membranes start to break down and can rupture the cell. The cell may enter into a cell death pathway with mitochondrial injury or DNA injury. So all of these cause injury when we remove blood flow from the organ. And you can see that there's this term we call ischemia reperfusion injury related to cell death, energy deficiency, vascular leakage, inflammation. All of this then is actually manifest clinically as primary graft dysfunction. We look at the function of the organ, whether from laboratory values or clinical assessment, and we see that there's dysfunction when there's more injury. So our goal with static preservation is to drive the metabolic rate down. So if it starts at 100%, we want to decrease it down closer to 0% so that these metabolic changes are not occurring. Our goal is to put the organ in some sort of a stasis or a static field. So you can look over here that hypothermic machine perfusion and static cold storage are the best at doing that. We drive the temperature down to less than a 10% metabolic rate, and we try to drive the temperature over this way so that we close or shut down the function of the cells and the organ in order to put it in a stasis. So there are many approaches to managing preservation of an organ. Static cold storage is listed here with some of the merits and challenges, including there's a very low cost associated with static cold storage. It's simple, it's easy to operate, and there's less opportunity for errors to be made. You end up with metabolite accumulation, and while the organ is in cold storage, it can be difficult to assess the function of that organ when compared to some of these other mechanisms in which we have machine perfusion and we're able to have real-time assessment of the function of the organ or the status of the organ. There are many preservation solutions which have been introduced and used as various times. Eurocollins, University of Wisconsin, HTK, HTKN, Celsior, Perfidex, IGL, all have different combinations of components but are all used for static cold storage. And of course, anywhere in medicine where there's a lot of options, there's going to be a lot of research and arguing back and forth about which is the best. I present this because I think it's an interesting study, but it presents an option for future research. In this case, we have preservation solutions. And the question is, can we add something to that preservation solution to make it more effective? And in this case, the researchers, this was published last year, took the hemoglobin from a bloodworm from the coast of France. And the hemoglobin has a very high affinity for oxygen, and it also releases that oxygen at a slow rate compared to normal human hemoglobin. So that hemoglobin was isolated and placed into a preservation solution. The study that was done then was to take paired kidneys. So there were two kidneys from the donor. One would get the hemoglobin added preservation solution, and the other had just the standard preservation solution. And you can see that when this hemoglobin, specialized hemoglobin that had the high affinity for oxygen, so it held the oxygen longer and it gave a slow release over time, those kidneys had a much more rapid time to normalization of creatinine compared to the others. And I present this only as an example of things that can be done in cold storage to still affect the function of the organs, and there is ongoing research in these areas. As far as clinical research comparing the preservation solutions, I would like to just remind you of what is the best type of study in order to study anything in clinical research. Case reports, case series, and case control studies have very low quality and are at high risk for having errors. When you start to get to retrospective reviews and registry analysis, it's somewhat better because there's a much greater number of patients. However, if there's any kind of a deficiency in the patient population in the registry, you're going to miss that, and that error is going to be propagated, whether it's 100 patients, 1,000 patients, or 20,000 patients. And I'll talk some about the registries and the limitations of those registries. I think single-centered data is very important in surgery and in transplant, because most single centers do the transplant the same way every single time, whether it's choice of the donor, choice of the recipient, immunosuppression protocols, and the way they do the surgery, it's all done relatively similar for most single centers each time. And so that gives you the opportunity to vary one variable, A and B, for instance, and be able to compare them. And so I think single-centered data is far superior to retrospective and registry data in surgery and in transplant surgery. Then we have prospective observation and then randomized controlled trials, where we determine beforehand how we're going to vary things, keeping everything else the same. And we do that randomly, and that minimizes confounding factors. So I think that this is very important, that the randomized controlled trials should always be the gold standard. It minimizes allocation bias, and it's the only way that we can truly prevent confounding factors from impacting on the outcomes. So again, confounding occurs when variables that affect the outcome are not evenly distributed among the study groups, and that happens very commonly in registry data. So first, I will talk about kidney transplant. Kidney transplant was the first of the organs that was studied in a randomized fashion between different preservation solution. This came from 1990 to 1992, and it was a comparison of HTK, UW, and urocolons. And it actually randomized 572 kidneys. This was a European study. And you look, and it was probably one of the best studies that is done comparing preservation solution, and it was one of the first ones. And you can see that the long-term graft survival at 3 years was superior for the HTK in this particular study, and they did account for age, cause of death, donor death, and cause of ischemia, and the amount of cold ischemia time. We started using HTK in 2003 at our center, so by 2005, we began to analyze the outcomes to determine if there were differences. The study that we used was HTK comparing it to UW, but we actually looked at it in a pulsatile perfusion. So every kidney was placed on a pulsatile perfusion machine. And we found no difference in delayed graft function, graft survival, or patient survival. And so we continued to use it as our primary preservation solution. Thereafter, we looked at it varying by amount of ischemia time, 16 hours, 24 hours, And we actually found that the HTK had lower delayed graft function compared to the UW. And so again, we began to use it routinely at our center for kidney transplantation. We also were doing a large volume of pancreas transplant, so we used it in that, and then we began to study it as well. Our first study was published in 2004, where we had 10 HTK and 10 UW, and we found no differences in graft and patient survival, blood glucose levels, and serum amylase levels. We then went on a few years later. By that time, we had accumulated 87 pancreas transplants. We had pretty much changed to HTK, so there was a difference in comparison, but we found no difference in patient and graft survival. There was a study published a few years after that, which came from University of Nebraska, and they looked at HTK 16 versus UW 81, and they found a high rate of post-transplant pancreatitis. And they suggested that HTK was the cause of that. And when they looked at the actual data, they found a very high 29% of all cases had graft pancreatitis, a 19% graft thrombosis rate in the HTK versus 4% in the UW. So they published this paper in American Journal of Transplantation saying that HTK in pancreas was dangerous. Of course, at the same time, we were doing 50 to 60 pancreas transplants per year using HTK and not having these results. So we continued to use it despite this. What happened, though, is a lot of people felt that maybe it was the high flush volume that was used in the HTK when compared to UW. And you can see here there was 5 liters versus 2.5 liters. And that was the cause of it. And so many centers after that began to use low volume HTK in order to avoid post-transplant pancreatitis, though there was not a clear proof that that was the etiology. Again, we went on to use it and have published several more papers, including this one in 2009 with above 90% survival. And now we've done almost 700 pancreas transplants. Again, HTK is our primary preservation solution, and our graft survival is 1 year, 93%. So we feel very comfortable continuing to use it. There was a paper, I think this was out of Chicago, where they used HTK and compared it to University of Wisconsin in isolation of islet cells from pancreas grafts. Looked at the two, 41 in one group, 45 in the other, found the number of transplant that they were able to actually to use the islets and transplant them was higher in the HTK. And if you look at the islet yield, it was higher from the HTK as well as the viability was very similar. So they came to the conclusion that there was not a lot of difference between the two, and it was okay to use them for islet isolation. There's just been one paper that's been published. We published this in 2008 for intestine transplant, intestine and multivisceral. In this case, we looked at 35 and 22, and we found no difference in initial function, appearance on early magnification endoscopy, episodes of rejection, transplant pancreatitis, and early graft survival. So we continue to use HTK for our intestine and multi-organ transplants. Now I would like to move to liver transplant, and I think this is where there's the most interest and controversy. So again, I would like to remind you that randomized controlled trials are the gold standard and the best way to evaluate this, because it minimizes biases, and it's the only way to truly prevent confounding. And the reason I mention that again is because a lot of the registry data that has been published does not have all of these various factors available to them as part of the registry. So in particular, when you look at a liver to decide if you're going to transplant it, one of the primary things you look at is graft steatosis. How yellow is it, and is it usable? Graft steatosis is not listed in any of the registries that have compared HTK and UW. So I think that's important to recognize, as well as all the rest of this. So serum sodium levels, history of alcohol abuse, history of liver injury, elevated liver enzymes, diabetes, cardiac function, cancer history. All of these factors are not there. And the reason I mention that is because oftentimes the people who are using HTK are also using high-risk grafts. So they're more likely to use grafts that have steatosis, come from an alcoholic, have been involved in a grade 2, grade 3 liver injury. And that's going to put them at slightly higher risk for graft loss. So that when we start to see a slightly higher graft loss rate, I don't know that we can say that it's a preservation solution or if it's a patient or donor selection issue. The thing I would say about the liver is the preservation of the liver is more complex than other organs. So you have arterial and portal vein flow versus just arterial flow for other organs. Also, you have this issue of the microcirculation, which provides blood flow to the biliary tree, and it's particularly important, and you don't necessarily see that in the other organs, but you can very easily end up with biliary strictures if that microcirculation to the biliary tree is not preserved carefully. It's also a very large and dense organ, so it's more difficult to rapidly cool and to fully exsanguinate. So you really need something that will flush out the blood very efficiently. So this is one of the papers that came out as a negative study when they compared HTK and UW. And this, again, was from a registry data. And they published a series of 3 papers in kidney, pancreas, and then liver saying that HTK was associated with higher graft loss. And I think I would have taken the statement, if I just saw that, I would have said, yeah, I guess that would be true. Because if they're equivalent, and yet the people using HTK UW are using higher risk grafts, I would expect a small difference in survival 5 to 10 years later. So again, they used the UNOS database for that particular study, and it lacks data on liver steatosis, liver injury, hypernatremia, donor risk, recipient risk. And in the end, they didn't report the causes of those graft losses. So this was followed shortly thereafter by a study out of Europe, René Adan, basically completing the same registry data. Now this graph shows the increased use in red of HTK over several years' time versus Celsior and UW, you can see, took up the bulk, but started to lose market share, and only by the end of this study was only about 40%. So I think it brings up a couple of questions: is why were people switching away from UW? I think HTK certainly is easier to use. It's the viscosity is similar to water, so it flushes very rapidly and provides a very good flush, versus UW, which has a very slow flush and it's very viscous. HTK is easier to use because you don't have to add things at the donor site to the solution. And so technically it's easier. And then I don't like to work with UW because it makes your gloves kind of sticky, and it can stick to the sutures as you're working to prep it. Regardless, these other solutions began to take over a portion of the market share. And then this study was published, and again, it used registry data from Europe and showed a similar outcome, to where there's a similar decrease in survival of about 10%. But all of that occurs, it looks like, in the first 3 months, again, which would suggest there's something that happens early on to differentiate these HTK grafts compared to the others. So those are negative studies that suggest that HTK does not have as good of outcome. The positive studies for HTK, if you look at the SRTR data, which comes from the United States, and it's basically UNOS data that has been cleaned up and made more uniform, and it shows no difference after analyzing thousands of patients. When you look at single country data such as Germany, they do not see any difference. And then many single center reports have been published from Cleveland Clinic, Indiana University, Michigan, and European studies showing no clinical difference. There have been several randomized controlled trials which have been done, which demonstrate no difference. And this Center for Evidence in Transplantation from the UK at Oxford, they did a meta-analysis of these randomized trials, and I will show that here momentarily. So this is some of our early data from 2006, where we saw no difference between the two. Early on, we were comparing approximately 200 in each group. And then we began to break it up into different groups, so standard criteria, extended criteria, different groups. And again, we saw no difference in graft and patient survival. This was back when our outcomes were not as good. They were in the mid-80s, but have since improved above 90% now. but you can see there was not a significant difference. If anything, the HTK was superior. I would tell you that in 2019, when I looked at this again with 2,300 transplants, 1-year survival was at 93%, and we still use HTK primarily. You can see here, looking at 1,300, this was from the World Transplant Congress in 2014. A multivariate analysis shows slightly superior outcomes for HTK at our center. This is the SRTR data that I mentioned before, which showed that the preservation solution did not make a difference in overall survival. And then this is the meta-analysis of randomized controlled trials. They went through 5,000 abstracts that had been published on any kind of analysis comparing the two solutions, and took out the ones that were relevant, found randomized controlled trials. And you can see here in the end, basically one means no difference, and the main studies that they looked at had overlap. If anything, it slightly favored HTK. This was from Annals of Surgery in 2014. I'll move on briefly here to pediatric liver transplantation. This is a consensus paper that looked at best practices in pediatric liver transplant. And because of the small nature of the vessels in the pediatric liver, they actually recommended flushing with HTK solution because it is less viscous and provides a better flush of such small vessels. And that was in their recommendations for pediatric transplantation. This is 2012 from American Journal of Transplantation. We compared HTK and UW at our center, and this is published in Pediatric Transplantation, and showed no difference between the two. This was from 2018. So now I would like to talk a little bit about donation after circulatory death. I will tell about our center because we've had a pretty dramatic experience with liver transplantation using donation after circulatory death. Initially, we were very aggressive in using those organs back in the early 2000s, from 2003 to 2009, but we had really inferior outcomes. We had 1-year survival of 70 to 75%, and that was not acceptable. And so our use of these organs went down dramatically. We began to use HTK custodial in combination with a thrombolytic, TPA, and we found our outcomes improved dramatically. And so our first report was published in 2016. And you can see here, this is all of our liver transplants, and we looked at HTK UW. Briefly, I just want to point out that our complication rates were significantly lower for the HTK compared to the UW. And here as well, ischemic intrahepatic strictures were significantly lower for the HTK in donation after cardiac death, specifically when we take out that subsection, 8% versus 36%. So we adopted this as our standard protocol. And our protocol, I want to go through it so that it's very clear. We heparinize fully the patient before withdrawal of support at the local hospital. We wait for circulatory death, which is declared by an outside physician. We then have a 5-minute wait time, which is pretty standardized in our country. We then make a rapid incision and aortic cannulation, vent the vena cava, make a sternotomy, cross-clamp the aorta, and we start flushing. Now we flush initially with the TPA solution, which is 100 milligrams of TPA in 1 liter of normal saline. We do that at room temperature because the TPA functions better at body temperature. We then let that TPA dwell for approximately 1 minute, and then we began a cold solution flush with HTK, 3 liters through the aorta. At that same time, we do topical cooling with saline slush or ice. We then perform rapid recovery of the liver. After we've taken the liver out, we infuse 100 mils of that same solution. So it's a 1 liter solution. We save 100 mLs, and we put that into the hepatic artery. We then put clips on the artery in order to store the TPA solution. Again, it's TPA with HTK custodial in the liver itself. The portal flush then is done with 500 mLs of cold HTK, and common bile duct flush is also done. And then we package and transport the liver in static cold storage. On the back table, when we prepare the liver for transplantation, we flush out that TPA solution from the hepatic artery so that it's not flushed in to the patient at the time of transplant. So you can see here, this is our first report on the outcomes. And you can see that our 10-year survival from that first era when we were not using the TPA was very poor, less than 50%. But when we started this protocol, it went all the way up. At 10 years, actuarial survival is almost 90%. So it was a very dramatic improvement. When we looked at subgroup analysis, so this is era 1 when we did not use this protocol, and then era 2 when we did, the TPA plus HTK, any need for biliary imaging went way down. Intrahepatic strictures was actually 0. So during this era 2 of 30 livers, DCD, we had no intrahepatic strictures. And so it was a dramatic change for our center. Again, HTK, this is just at a 3-year log rank analysis, was far superior to TPA and custodial together. So the best survival at 1 year in DCD was the HTK compared to the UW. The outcomes, actually what we looked at was DCD versus non-DCD livers at for 3 consecutive years, and we found similar outcomes. We did not find any intrahepatic strictures over the first 4 years of using this combination together. So again, it was a dramatic improvement for us. So that allowed us to start using more extended criteria donors under a DCD protocol. And specifically, we started to look at donors over age 50, body mass index greater than 35, warm ischemia time greater than 30 minutes, macrosteatosis greater than 30%. So normally we would have turned these down for donation after circulatory death protocol, but under this new era, we chose to use those. And so here we looked at the era number 1, extended criteria donors and their poor survival. This is at 7 years. Versus era number 2, again, same extended criteria donors. And we had a dramatic improvement just in this subgroup of patients who met those criteria that I mentioned before here. So then we looked at era 2 and we matched our extended criteria DCDs compared to our brain dead. And we found no difference at 6 years in survival. So we were able to achieve very reasonable results using DCD, even among extended criteria donors. And so this is a summary of our volume of donation after circulatory death livers up through 2018. You can see we tried to use them early on and had very poor outcomes. And so for about 3 years, we effectively did not use them. Then as we instituted this new protocol and found success, we started to increase the volume dramatically, up to the point where the last 2 years, our DCD volume has been about 25 to 30% of all of our transplants. So it's become a very important part of what we do every day. We found this very concerning then when the ILTS published their expert consensus guidelines for liver transplantation from DCD donors, and they included 2 components that we think are critical to success at our center. First, they suggested that HTK is associated with higher risk of graft loss and therefore it shouldn't be used, which again is very counterintuitive to what we do every day. And their evidence from that for saying that within their guidelines was the registry data that I mentioned before. So we very strongly disagree with that. And then the second thing that they mention is lack of evidence in supporting the risk of fibrinolytic agents. We think that fibrinolytic agents are critical to success. And most of the high volume centers that use DCD grafts in the United States use thrombolytic agents at some point in the process in their protocol. So these were published recently in 2021 in Transplantation, and we disagree with these 2 facts that they present. So in conclusion, for these preservation solutions, primarily HTK, UW, and IGL are the ones that are in common use. We found no significant difference for kidney, pancreas, pancreatic islets, intestine, and in liver, including DCD, kidney, and liver. We think that it's possible to decrease biliary complications when you're using custodial HTK because there's potentially a better flush of the biliary system, and our data of over 1,400 patients demonstrates lower biliary complication rates when comparing HTK and UW. HTK is safe for use in living donors. We've used it in both kidney and liver and had no problems. And we think that there's a benefit to using it specifically in donation after circulatory death because of its low viscosity. We think it provides a better flush. And when we use it in combination with the thrombolytic, it's allowed us to very dramatically increase our volume of liver transplant using DCD livers. So future research would be the optimal flush volume. If you look at the actual package inserts for HTK, it recommends somewhere between 10 to 12 or even 15 liters of flush, and many centers still do that. We have always just used the same 3 liters, whether it be 3 to 4 liters, whether it be HTK or UW. We have not changed that. There are generics now available and in common use, and we continue to use even the generics at the same volumes, and we've not noticed any difference in using those. The question of custodial HTK plus TPA, this combination being protective against intrahepatic biliary strictures, I think is still open for research, and we need more evidence from other centers, but our center certainly has shown it to be successful. What is the best solution for prolonged cold ischemia time? I don't think we know that. We don't ever allow our livers to go any longer than 12 hours, and our average is more around 5 to 6 hours. So we were able to get them in very quickly, and we think that helps. And then as far as use in normal thermic perfusion pump, I don't know yet what's going to be the best solutions in that setting. So those are some of the areas for research, and I'm happy to stop there and take any questions.
Richard, excellent presentation. You really started very quick. I didn't have the chance to introduce you. For those who were not present last, the first attempt to start this meeting, Richard is the chief of the Indiana Transplant Program. He's a good friend. He's one of the biggest experts on intestinal multivisceral transplant and as well as liver transplant. And I really would like to thank Richard and apologize for what happened the first day of this meeting. I'm glad that so far we're running very well. And I hope that we can accomplish some of the questions. I know that Dr. Marasquio has joined us. He's one of the chief of the liver pancreas transplant program in Colombia, in Cordoba, in Argentina. And I would like to have Martin asking or making some comments, and then we will follow you up. Thank you, Martin, for being here, and it's all yours.
Well, congratulations, Dr. Mangus. Excellent presentation. Thank you very much, Gabriel. I have a couple of questions for Dr. Mangus. First one is, have you observed a lower rate of graft pancreatitis with low volume donor aortic flush? Because in our experience, we have observed a dramatic increase in the graft pancreatitis after we started using HTK, which was the only preservation solution available in Argentina for several years. So that's one question. And the other question is that I assume you haven't, but have you observed increased hemorrhagic complications after usage of HTK plus TPA for donor aortic flush? Thank you.
Yeah, thank you for your questions. I think these are both excellent questions. And as I mentioned before, there have been other centers that have said that they have increased graft pancreatitis. Our center at its peak was doing 60 pancreas transplants per year. We did not see that, and we continue to use it on a regular basis. Our volume has decreased to around 25 to 30 pancreas grafts per year, but we continue to use it and have not seen that. I think that we follow the low volume protocol pretty strictly. We already, as I mentioned before, only use 3 to 4 liters. There are certainly some centers that will use even less depending on if they're taking the pancreas or not. And then there are other centers that simply won't use HTK when the pancreas is being procured and they use a different solution. I think I don't have a good answer. I think it appears to be center specific. I don't know if there's a difference in procurement or what the difference is. If it doesn't work for your center, it's certainly not worth the risk of those graft losses and making the patient suffer through, a poorly functioning graft. If you don't feel comfortable with it, I don't think you should. That's number one. Number two, do we see hemorrhagic complications? I would have to say that sometimes we do, though I wouldn't call them complications. When we reperfuse the liver after the donation, after circulatory deaths with the TPA, there is still TPA that's left in the system, and it does get flushed into the patient systemically, and we do see the patient become coagulopathic. I would not say every time. Oftentimes we use aminocaproic acid as an antithrombolytic agent. So you know, you're kind of comparing a couple of different agents simultaneously. Usually we're able to make the bleeding stop within 20 to 30 minutes, and we don't notice a big difference in the end. We don't have an increased rate of having to go back to the operating room. Having said that, we have a very low threshold for just only like packing around the liver, closing the skin, and coming back a couple days later if we're concerned that there's going to be significant bleeding. So as far as graft loss or graft injury, no. And I think we've come to the point at our center where we're willing to trade off that increased bleeding at the time of transplant for not having any biliary complications and being able to use these livers.
Thank you very much.
Gracias, Martin. Richard, I have from YouTube one question, which is, do you have any clinical or experimental experience in preserving intestines from DCD donors with HTK and thrombolytics?
So I do not know of any center in the world that has done DCD intestine transplant, and you can correct me if I'm wrong. So I have zero experience, and I don't have any experimental or laboratory experience at all, because we have not ever published anything like that. So I don't have an answer on DCD.
Richard, to give you an answer, in 2019 in CIRTA, there was a presentation from Taiso Hibi about Asia, and I was very impressed because they report 12 cases of intestinal DCD donors from China. There was no expansion about how those organs were procured or under which circumstances, and this is something that we had to keep it apart for discussion, but this is, to my best knowledge, the only experience on DCD being used in the clinical field for intestine. I would like to add a couple of questions, Richard. One goes with what Martin was asking. If you had to tell Kohler Chemi, which is the company that produced HTK, to change their recommendations for use, will you tell them to change the volume that is required? Because I do agree with you that most of the centers continue using 10 to 12, and coming from a low or middle income countries, the reduction of the volume also goes hand by hand with reduction of cost. And certainly that will, allow probably us to optimize the use of this solution in our patients. But also I do agree as well that less volume is required for pancreatic preservation as well. Although in our center, and we are writing a manuscript about this right now, in liver, in pancreas, and in intestines, although the numbers are low because we have only 7 and 7 cases to be compared versus UW, there has been no significant difference using UW or HTK as you present in your talk. Therefore, my first question is about the volume, and they should change the brochure. And the second consideration is, if you are having such good results using thrombolytic agents on DCD, why not using it in all donors? Because regardless of not being DCD, diffuse ischemic biliary injury remains one of the major causes for retransplant in liver transplantations and with brain dead donors. That's why that can this change might contribute to reduce this risk. What is your thinking about?
Okay, the first question about decreasing the volume, a company, any pharmaceutical company cannot just change their package insert and their instructions without research backing it up. And so I've actually at TTS, when it was in Korea, even though it was canceled, I had a paper accepted there where we looked at the actual volume of preservation solution being used in our country. And I compared all the different centers, and there were probably 20 or 30 different centers, and almost all of them that had come into our system, into our OPO, and done a preservation were using 3 to 4 liters. So it was already the standard. And that was, I looked at, I think, 1,000 livers that had been procured, and everybody was already using equivalent volumes of HTK UW in their daily practice already. And so I'm in the process of working on a manuscript where I'm basically going to publish that and demonstrate that that's in common practice and use across many over 100 centers now in the United States that use that routinely, so that they will have some evidence to be able to make an appeal to be able to change that recommendation. But I don't dictate what they do. I simply see where research needs to be done, and then I try to do it to answer these important questions. That's my first one. The second is using TPA in all. Well, the big problem that any country has in using the TPA is it's very expensive. And so in our country, we don't have streptokinase available. We just have TPA, but the TPA can cost $5,000 per dose. It's very, very expensive. But of course, when you compare that to the cost of losing a graft and redoing a transplant, well, it's money well spent in our decision. If you estimate that the cost of a liver transplant, again, in US dollars and in our country, which is different from anywhere else, around $400,000. But if you spend $5,000 to assure that transplant's going to be successful, it's good use of money. I think the more important question is streptokinase, would it have the same outcomes and be dramatically less expensive? And I think that it would be. And so I would, the other countries that have access to that, I would encourage them to potentially try that and then publish the results to see if that problem could be fixed, the problem of cost.
Richard, you know that after the famous and controversial manuscript from Renee Adam, there were 2 letters to the editor published that explain something of what you mentioned in your presentation regarding about how the study was done, all the bias related with the organs procured in Germany, which constitute more than 70% of the total number of donors, and in which particular population, most of them were obese donors as well. And also they did a different type of multivariate analysis that finally showed that the difference did not exist. That's why I would like to give the word to Dr. Gonzalo Rodriguez from Alicante, who's here and who has just sent us a question to the chat, but I would like him to ask the question for you. Thank you, Gonzalo. Please go ahead.
Thank you, Gabriel. Richard, congratulations. I love your presentation. And we are, in fact, good HCK users. It's our only preservation solution. And we try to minimize ischemia time. We keep about 4 hours and change of cold ischemia. We try to synchronize quite well. But in fact, my question was, can you think of any lobbyist or extra medical reason why such claims are made against HCK? And I'm backing up what Gabriel just mentioned about the Eurotransplant registry data. And that's what happened. Most of those livers from Germany were actually transported outside of Germany. And interestingly enough, in those articles, the longest cold ischemia time was 9 hours or so for the HCK set. And everything else was lower. And that made a significant difference. And then they're claiming that all conditions being equal, HCK is a bad thing. So do you think of any particular reason other than lobbying or who knows what for such claims to happen?
Well, I guess my answer is very cynical. It's money. I showed you how UW in the late 90s was basically 100% of the solution being used. And over the course of about 10 years, they went all the way down to 40%. So that's a dramatic change in market share. And so I think it was, again, in their best interest to highlight data that would improve use of their product or disparage the use of another product. I get frustrated because, these are scientists who should identify the weaknesses of registry data and the confounders and go through that process before they just publish these papers. They took the variables that were available to them and said, we controlled, we use multivariate analysis, it's done. but they didn't really think it through. Well, what are we missing and why are we missing it? And should we still publish this even though it's weak? That's number one. And number two is, again, I don't know why these people had an agenda, because they published it in the best journals, Johns Hopkins, 3 articles in a row. But when you look back and you look at the SRTR data, which is much better data, it's just not true. And so it's frustrating because, I think it's scientifically inaccurate and ethically not correct, because you should have done better research. Why they have this agenda, I don't know.
Must say one thing that you mentioned briefly about the use of TPA, and we did use that back in New York for when we do the ultra fast extraction on the DCDs. But here we do have the luxury of using UK urokinase, which is a lot cheaper. We don't have the streptokinase, but we do have the urokinase, but since we started the normothermic regional perfusion, we try to avoid the ultra fast removal of the organs. And last week it was also mentioned, long talk about that. And if you do have the luxury of using a pump, then you don't need that. You heparinize the patient and that you're safe, you're golden. But using UK, actually, I think it might do the same. And it's a nice idea. We haven't really needed in here, but should we need to do one ultra fast, at least thinking of that and adding on the way you put it, it's nice. And I appreciate that contribution. What
is the cost of the UK? Do you know?
I do not have it offhand. I would take it out of my hat and say, but it's probably about a third or a fourth of what TPA costs for us in here. It's not like 10-fold or anything changed, but at least 3 or 4 times cheaper.
Yeah, I've very much lobbied at our center to be able to get that, and they just don't have it available. So we have to use the more expensive, and I would prefer not to.
Okay, great. Thank you.
Richard, I would like to see Liliana Viciniano, who's here, also can turn on the camera. Liliana is the scientific director of the Argentinian UNOS. It's called INCUCAI. I would like to thank Liliana for sharing us today. And, it's important because Liliana is one of the responsible for developing a system that is called Sintra, in which we include all the data for donors, recipients, and we have the national outcomes. And what you mentioned is absolutely correct. And I'm very pleased that the Argentinian system has evolved and changed already over time, because most of the registries are developed years ago. And I recently wrote a manuscript against the Japanese exemplar, which is the Japanese pediatric liver transplant experience from the beginning. And it's interesting because they have been performing liver transplantation for more than 28 or 30 years, but the database has not changed over 30 years. That's why the 30 years after, they have the same variables to be analyzed. And I think that what you're saying is similarly in UNOS and similarly also in Eurotransplants, where there are a lot of data that are confounded and missing. Like, for example, maintenance. It's not the same, the amount of drugs that you receive or you receive acknowledged when the organ gets offered, than the real drugs that are being used when you arrive to the place and for the retrieval. And this is part of life. And I think that this data is required to have a better assessment. That's why I don't know. I mean, I agree with you, and I would like to see what do you or can you comment regarding also UNOS, because you are in United States, or Gonzalo in Europe, to see if it's possible to update and change those databases to make them more usable for us.
Well, my main area of research is liver, and again, I think that one of the most critical factors in the liver is steatosis, and yet, if you put 2 pathologists side by side, they will disagree on the amount of steatosis. So you can't even enter it into the database because you can't get anybody to agree on what the true number is, and yet it's probably one of the most critical variables you could have. So when I included in my studies, my database is around 2,500 since we started here. I have to go and look up the original slides, the original reports, and have the same pathologist look at each of them and grade them, so I know what I'm working with. I have to do it by hand by myself. So that's an example. It's just very labor intensive.
Definitely. Okay, Richard, I would like to thank you twice for giving this talk. certainly we value your assistance to being here and all your scientific work done. Really, it's very, very useful. We follow you, and you are invited to stay. As you know, this was the preservation for abdominal organs. Now we're going to have a 5 minutes break, and then we are lucky to have Dr. Ronaldo Onorato that will be introduced by Dr. Candiotti and Dr. Bertolotti, and then we will continue talking about preservation in thoracic organs. Thank you, Richard, again, and we'll be in touch.
Thank you for the invitation.
We will restart in 5 minutes. Thank you.
Hello.
Hello, Dr. Honorato.
Hello, Pablo. How are you? Are you hearing me?
Yes, Dr. Honorato, I hear you. We restart the day in 3 minutes. Hold on, please.
Bueno, buenas tardes a todos. Retomamos la actividad de preservación estática. Ahora nos toca el módulo de tórax. Quiero presentar al doctor Candiotti, médico cirujano de trasplante cardíaco pulmonar y cardiovascular general de la Fundación Favaloro, y al doctor Alejandro Bertolotti, quien es el director del Departamento de Trasplante, jefe de cirugía cardiovascular, quienes han tenido la delicadeza de acompañarnos hoy, junto al doctor Mariano Brancic, que también es médico cirujano del Instituto Cardiovascular de Buenos Aires y que se suma a la discusión que vamos a tener posteriormente a la presentación del doctor Ronaldo Honorato, a quien agradecemos desde ya. Mariano, Alejandro, la palestra de ustedes, gracias por acompañarnos.
Gracias, Gabriel. Buenas tardes a todos. Hoy tenemos el honor de tener como speaker al doctor Ronaldo Honorato, quien es cirujano cardiovascular y de trasplante del Instituto del Corazón, INCOR, San Pablo, responsable de las evaluaciones cardíacas del mismo instituto y miembro de la Cámara Técnica Estatal de Donación para Órganos Cardiotorácicos. Doctor Honorato, si quiere compartir su pantalla e iniciar su presentación, el tiempo es suyo.
Doctor Honorato, usted está muteado. ¿Podría abrir el micrófono? Can you open the mic? It's mute.
All right.
Oh, yes, perfect.
Yes.
Thank you.
All right. Would you like me to speak in English or can I speak in Portuguese, or how we would say in Portuñol?
Whatever you feel comfortable, Doc.
Okay, I'll speak in English. I'll share the screen. Just a moment, please. Here we go. I return to the meeting. I will share the screen, and here you go. All right. Here we go. Everything okay? Are you hearing me?
Yes, it's okay.
Okay. First of all, I would like to thank you very much for the invitation, and I will try to show you some data from our Heart Institute here in Brazil, which now we can perform 55 up to 55 heart transplants only for adult group. We have a congenital transplant group, which performs more or less 20 up to 25 heart transplants a year. So
I apologize, but we can only see a white screen. I don't know if you have to change the selection, please.
Right now.
Yes, perfect. Thank you so much.
Okay. So we have two different teams. We have an adult team. I am the coordinator for the transplant adult team, and we have a congenital team. Our whole institute here in Brazil performs about up to 70, 75 heart transplants a year. So I'm going to show you our experience with extended ischemic time using custodial. It's just a single center. In Brazil, we are the center that perform more heart transplants. We perform about 55 heart transplants a year, from 50 up to 55 heart transplants a year. Despite of this pandemic time, we made last year 52 transplants, and up to now, we perform 37 heart transplants in the Heart Institute, and we are transplanting in another private hospital, which are about 18 heart transplants at the time. So we have at the time 53 heart transplants, our team. So I'm gonna begin my presentation. Excuse me, here we are. We are the Heart Institute in Brazil. We are a huge institute. You can see the old building and you can see the new building. We all know that the heart transplant is beginning. It begins in 1982, and now we have a lot of heart transplants being performed, especially in countries such as Europe and North America. And we are growing to do this kind of transplants in South America as well. Our Kaplan-Meier, as you can see here, we have a great Kaplan-Meier. We have good adults survival, and we are improving these results. And I'm going to show you these results regarding of the extended ischemic time. We have all of us know that we have a very well-known problem. We have a limited number of donors. In Brazil, we have 47% of the families that refused the consent to donate the organs. So we have 17 donors per million of population, and only 33% of them are effective donors. So we can work on them. We have a low utilization capability. Our team use more or less 10% of all of the donors, all of the hearts that are offered for us. And the major problem is the maintenance of the donor. We have a public system in Brazil. All the transplant system in Brazil, the national transplant system in Brazil is free, is a public system. So we have a huge problem because our hospitals are not so well prepared to maintain those kind of situations, those kind of patients, which are very unstable. So we have a lot of number of recipients that stays in a priority status. Our team performs 88% of the transplants we perform in a priority status, which lead us to a high mortality rates on a waiting list. On the pandemic time, we have 35% mortality on waiting list, which is very, very high. Before the pandemic time in 2019, we're about 10% on the waiting list. So we have to use many strategies to alter this scenario. How long can we go? How long is the ischemic time? Can you use the hearts? And the reality, more than 50% of our hearts come from a distance harvesting situation. So despite of living in a big city, which is São Paulo, about 12 million people, believe it or not, more of 50% of our hearts come from a distant harvesting. So you use it a lot. As you can see here in Brazil, we have a lot of deceased donors in Latin America. In Brazil, we have almost 3,000 deceased donors. We have a consent donation here in Brazil, and we can only use, as I told you before, 10% of this kind of situation, this kind of donors. Despite of this, as you can see here, the Brazilian register shows that Brazil is the second one in the absolute number of transplant. As you can see the kidney here, you can see 2019, you can see Brazilian situation here, and you can see, of course, your situation here, which is Argentina. So we are in the second place, despite of this kind of scarcity we have of our donors. In the liver, we have almost the same. We have the second place as well. And despite of the pandemic time, we have 2,245 livers donors transplanted. But when you see the donors per million population, we are on the 21st place. We are very far away from the situation that we are more comfortable and we wish to stay. Here you can see you have all the refuses, all the causes of death. As you can see here, all the causes of death. You can have external causes, that we are trauma, that we are firearm, gunshot, and we have neurologic situation here. As you can see, we should have this number of transplant. Our estimated necessity for heart transplant in Brazil is more than 1,600 transplants. We only performed in the pandemic time 300 patients. So we have a very dramatic situation here in Brazil. As I told you before, 88% of our heart transplants we perform in a priority status. We almost do not transplant from patients who are awaiting home. And this you can see here in our numbers. We're quite well before the pandemic time, but with the pandemic, we have a very huge drop in the number of transplants, as you can see in the number of kidneys and in the number of liver. But what is the promise, the organ to preservation? How can we transform this? It's a problem worldwide, and I believe it's a problem in Argentina as well. And the waiting list additions, we have more waiting lists every year. So we have death from end-stage organ disease that is growing day by day, that is going year by year. And how we know that? Christian Barnard on the early days, the first transplant in the world, in South Africa, and it survived only 18 days. This is Professor Zerbini, who performed the first heart transplant in South America, in Latin America, I would say better, in 1968, and very close to the situation and the tragedy of the record of the heart transplants. In the 70s, in 1970, we have the period that was very uncomfortable for those guys, for the transplantation team, because the patients survived quite a few days. It was a very huge situation, the status of death and how to perform the confirmation of the brain death and to do the heart transplant. So we have a necessity. The necessity is the mother of invention. So we have actually certainly, and the father is the act is certainly the father. And now we have to improve this scenario. We have to change this scenario. So we made a heart transplant team. From 2012, we made with our director board of professors, we decided to implant this heart transplant team. And what we could see? We could see that we have limitations. We could see that we have to develop the heart centers. And then we created the heart transplantation center, nucleus, I would say. We have cardiologists, we have cardiovascular surgeons, we have nurses, and we have biomedical scientists that work together. We have a space here in the Heart Institute that we share this place, and we work all together 24 hours a day. So our focus here is in the heart transplant, in the transplant at all. So we used to share with intensivists, infectologists, pathologists, all these kind of people. They share the meetings with us. They discuss acceptance of our recipient, and we have a full-time integration with the cardiovascular team and the cardiologist team, as well as with our nurses. We use a portable echocardiogram to evaluate potential donors, and we use to have a long-distance organ harvesting as a routine. So as you can see here, the preservation enables the key for transplant capability. So enhancing the transplant viability, increasing the pool of donor organs, expanding transplantation access, and perhaps galvanizing research, which are pillars for us to proceed and to grow and to keep growing year by year. Before the heart transplantation team, we compare two eras: before the heart transplantation team and after the heart transplantation team. We analyzed the heart transplantation rate, 30-day mortality, mortality on waiting list, and organ utilization rate. And as you can see here, the results were very substantial. They were very significant. Before heart transplantation, we have a rate of 14 transplants a year, and now we quickly rose to 36 transplants a year. We have a 30-day mortality, 29%, and we surprisingly dropped it to 18 heart transplants, 18% of them. We thought that we will have more death because we have many patients that were too long waiting on the waiting list, and we expected a higher level, a higher 30-day mortality. But what we could see that we have a very good mortality on this scenario. And what you see here, number of transplants and 30-day mortality. As you can see here, dropping year by year, increasing year by year, and we have 44 heart transplants on the year 2014. So this was very important for us, and this show us that we are on the right way, showing that the mortality in the waiting list dropped from 61% to 33% on the waiting list. This situation put us on a very comfortable but a very serious situation, because we have the seventh situation, the seventh center of the world, if you compare the numbers. But it was difficult for us to see this kind of scenario. We have a lot of organ offered, and we have still a low use rate of these organs. So we could drop it as well. Since the organ offered, they dropped it quite a little, but as you can see, we raised from 107 to almost 190 hearts. So we have a 14%, which leads us to 40% of increase, which was very significant. So we could increase the number of transplants, we could increase the organ utilization rate, we could reduce mortality in waiting list, and we could reduce 30-day mortality, contributing to improvement in our heart transplant team. As you can see here, we have the whole historic scenario here, and when we have the heart transplantation team, we have a very high utilization rate. As you can see here, this is our state of São Paulo system. As you can see here, more than 77% of the heart transplant waiting list, this is the situation of the whole state of São Paulo, are on a priority status. In our team, we have a priority of 87%. As you can see here, we have a higher number of patients waiting on the priority status because we are, as I would say, we are a reference center here in Brazil. At the time we use intra-aortic balloon pump, we have acute retransplant, we have cardiogenic shock, and we have those intra-aortic balloon pump and cardiogenic shock with drugs, only with drugs. We have the most important patients. We have 102 patients in the intra-aortic balloon pump and 75 patients on cardiogenic shock, as you can see here. So we have 50% on the intra-aortic balloon pump plus inotropes, and 38% of our priority patients on inotropes. This is important to see because we don't have mechanical circulatory support. Our mechanical circulatory support is intra-aortic balloon pump. And for those who are heart transplanter here, they know that this is a not ideal situation comparing to the world scenario, but this is what we have. So the standard criteria are restricting heart transplantation for a long time, since 1996, as you can see. But this shows us that we can go a little bit further, that we can be more aggressive in using those hearts, especially because this was a concern, as you can see here, that the first situation for death in the 30 days was the graft failure, which are followed by multiple organ failure and infections, as you can see. And we have almost this kind of situation. But in the beginning, we are trying to use the solution. When we start to use the solution, the custodial solution, we was very concerned about this kind of problem. And as you can see here, look at this, distant heart transported. The long distance, more than 1,000 kilometers, compared to those that were not so far away, show that was feasible, that was possible, and the patients here on inotrope support days, how many days, and the patients that were close, despite of those that were far away, including the ischemic time here, as you can see, showed that it was very curiosity to know that these data are not so well known. In Brazil, we have a surgeon in Brasilia, which was Fernando Atic, that showed that there is no impact, and it shows the heart transplant waiting list status. So it's important for us to do this kind of situation. So we have to have a good solution to use it. As you can see here, we have transplants from heart. This is a state list in Brazil on the São Paulo state. And as you can see here, you have almost 77,000 organs and 841 transplants performed. So we have a lot to go and have a good space to grow. So this is the situation. And we have only a difference of 34%. As you can see here, in Brazil, we have many patients from many heart transplants from other states. We are now with 398 heart transplants performed. This situation here shows that we have many patients, many donors that came from a lot of situations. As you can see, 161 organs were harvested from this kind of situation, or almost 300 transplants, which lead us to 53% of this kind of organs. As you can see here, Brazil is a very big country, is a huge country. We are close to you, as all of you know, close to Argentina. And we come here. These dots shows all the places we used to go, including this kind of place that was close to Argentina, always border to Argentina, which is very far away from São Paulo, which is here. São Paulo is here. So you can see we go very wide situation. We have this kind of, how would I say, fluxogram, this timetable. We use many airplanes. We have a flow chart that shows us how many kilometers should we use, which kind of airplane should we use, and we can, believe it or not, use carrier airlines in order to go and to harvest the situation, to harvest the organs. These are the planes we have. We have a Brazilian Air Force, which is here. Those airplanes are very old, 40 years, 45 years of age. But we used to have this kind of situation also, this kind of jets, because we have, how would I say, some financial support from the state of São Paulo. And we use, as I told you, conventional commercial airlines. And of course, we would like to use this kind of situation with a Learjet here, with a jet close to our president, Brazilian Air Force, President #1. But this kind of extended distance allograft can successfully be used, impacting a long-term survival. And we said this kind of situation as well. As you can see here, demographics comparing donors from up to 500 miles, more than 500 miles, up to 1,000 miles, 1,000 miles, and more than 1,500 miles, which is very far away from us. We don't have this kind of, how would I say, courage to go so far. And what they saw this kind of results. The overall cohort, 89% of survival. 500 miles, 88%. As you can see on this kind of situation, they almost have the same result. We believe that when we have this kind of situation, a very far away organ to be harvested, we have more detailed information from the donor, we have more integrity of the team, we plan it a little bit more, and we try to make it safer and faster, and the whole team is all focused on this kind of operation. And we am going to show you the results we have with this kind of situation. all you know that ischemic time is a very important situation. We have patients that go more than 4 hours ischemic time, and I'm going to show you this kind of patient. We have many strategical pillars. We have an extensive knowledge in myocardium protection, and we use minute logistic algorithm, which is frequently assessed. Constant communication between the teams. We constantly talk between the harvesting team and the implant team. We have a huge experience in this kind of situation, and we are always openness to incorporate new technologies and process. And constantly we review our data and make critical analysis in order to perform better. As you can see here, we try to use a box that is for carrying organ, which we control the time, the temperature, excuse me, the temperature. As you can see here, this is used in the European system. This is how we use to put the organ, the heart. So the heart comes inside these boxes, inside these recipients, and the lymph nodes come separately on these other recipients. Our myocardium protection. We exclusively use custodial as the main protection, and we use it as improved solution. And we would like to use it improved solution in the near future. As a routine, we use 2,002 liters during the harvesting, and we go to the back table. After removing the heart from the donor, we have it on a back table situation, and then on that situation, we perform another liter of the solution. And then we bring it to the Heart Institute, immersed on the custodial. There is no ice touch. We don't use ice at all. We use only a cold saline solution that is in order to protect the organ, so no ice touch. This gave us a large experience with the solution. This gave us a review of our protocol, so the resident can replicate our method. It's quite simple, and we are always looking to improve the process, as all you know. We always take the temperature of the solution that we are infusing, that we are going to the ascending aorta. And here is one of our videos that we can see the situation, how we on the back table situation. You see, it's only custodial. You see no ice. We take we used to do it very calmly, very easily, and very reproductively. So the residents and the chief resident, they can go and they harvest the organ. Then we take the temperature of the organ, the temperature of the heart, and then we go to our Heart Institute with it. So the results, which are our results? We have 396 consecutive heart transplants from 2013 to 2021. 65% from these donors are more than 4 hours. So we have patients that goes, we have groups, we divided into 2 groups. One group from 4 up to 5 hours, that we have 58 heart transplants, and more than 5 hours, we have 10 heart transplants. From the total, this 15% of the patients were transplanted with a very long ischemic time, and 10 heart transplants were performed with more than 5 hours heart transplant. What are our results? We have 18 patients that died on this kind. From 65, 18 patients died from this scenario, 25%. Infection is the most important cause of death of our patient, because our patient, they stay waiting on the heart transplant situation for more than 4 months. Is the medium waiting time. It's about 4 months. We have 4 PGD, we have 2 strokes, we have, believe it or not, 1 blood mismatch, which was harvested in Minas Gerais, in a state very far away from São Paulo. And one cause of that was indeterminate. We lost the contact with the patient and the family, and we did not know why he died. And we have one patient who died from COVID coronavirus 2019. From these patients, when we analyze the groups from 4 to 5 hours, you see that infection is the great ghost. We have 46% of our patients that die from infection, and PGD was the second cause of death. We have 4 patients die from PGD. But those guys, from 5 hours, we have only 3 deaths, 2 infections and 1 from PGD. Now, we are more or less, we have 6.77% of PGD from our cohort. And what we see from these deaths, as you can see, the patients die on infection on those days. As you can see, day 22, 23, 26, 37, 39, 49. And the PGD, which was more or less 6% of the cases, 25% of the deaths. And we have on the patients with more than 5 hours, we have infections and PGD. This is our survival rate, that curve or beta that we are experiencing right now. This is from January 1st January of 2021 up to right now on September 2021. We performed 35 patients, and we have a survival rate of 90, 93, 96%. On the pandemic, we have a little bit lower survival rate. We made 52 heart transplants, and we have this kind of situation. We have 80.77 survival rate, and now we have this kind of scenario. We made another heart transplant. In fact, we are performing a heart transplant today. Our team is performing a heart transplant today, and we have this kind of survival rate, which I think it's very good, which is very great. But I think it's time to go, and it's time to improve, and it's time to learn a little bit more in order to keep going and keep pushing more transplants. We need to do more transplants. It's necessary to do more transplants. Our patients deserve this from us. They expected this from us. And now I'm going to show you a real-time video from one of our heart transplants in a real time. I would say again, in a real time. As you can see, the organ, the heart, is now being reperfused. As you can see, note that it's becoming red and is real time. As you can see, this came from a long distance heart harvesting. You can see right ventricle, you can see left ventricle, and then it's very impressive to know how the organ recovers and how we have it. We used to transplant in a normothermia. We don't use hypothermia. All of our patients, we perform a normothermia temperature on the recipient. As you can see, it's becoming to get fulfilled, receiving the heart, receiving the blood. You can see how it recovers, how good it recovers. And this is the best situation all of us which are heart transplantation would like to see, isn't it? It's a good situation, and now you can see no cardioversion at all. That was not necessary. Fortunately, no need to cardioversion. And then we go, and here we go. And this is the final result. As you can see, the heart is now pumping well. And we have a curiosity here. We don't use inotropes on leaving the cardiopulmonary bypass assistant. It's curious because we don't use it, because it was on the, I would say, on the past days, all the anesthesiologists, they used to leave the cardiopulmonary bypass with a large amount of drugs, and we moved and we decide not to use inotropes. So we decide to use inotropes according to the necessity of the heart, since it's winning from the cardiopulmonary bypass. I would like to thank you. I would like to congratulate you for this kind of meeting and to try to move very forward from these systolic patients. And I think it will be very important for us here in Brazil as well, because we can expand the pool of organ donors, because we can expand the use of hearts. And that's it. Thank you very much.
Thanks, Dr. Renato. I would like to congratulate for your presentation. Was very insightful and full of data. And if you don't mind, I will continue speaking Spanish because I feel comfortable that way. It's okay for you.
Okay.
Una pregunta antes de pasar a las preguntas de los demás participantes. ¿Qué espacio cree que tienen los dispositivos de asistencia de preservación normotérmica más allá de la hipotermia estática en frío? Y la segunda pregunta es, vi que tomaban temperatura de la superficie del corazón inmediatamente luego del retrieval. Quería ver si en base a esas temperaturas modifican las actitudes, si pasan más perfusión, si les cambian algo su conducta o simplemente toman la temperatura para saber en qué temperatura se encuentran.
Esta es una pregunta para mí.
Sí, yes.
Sí, en Brasil nosotros no tenemos muchos dispositivos de asistencia circulatoria mecánica. Lo que tenemos mucho en nuestro instituto es intra-aortic balloon pump. Los dispositivos en Brasil son muy caros. Acredite usted que nosotros tenemos que pagar impuestos, tenemos que pagar taxas para hacer la utilización de dispositivos acá en Brasil. Los dispositivos custan casi $200,000 here in Brazil. Es muy difícil to use los dispositivos. ECMO nosotros estamos usando un poquito más ECMO ahora, pero también es muy difícil para usarla porque nosotros tenemos una limitación económica, es muy difícil para usar ECMO. Nosotros no tenemos experiencia con los otros dispositivos como Centrimag, como Berlin Heart, tenemos mucho poca experiencia, tenemos apenas en la práctica privada, que es muy pequeña. La temperatura que tomamos en corazón, nosotros hacemos que es muy importante porque cuando colocamos hielo, nosotros hacemos una gran preocupación con esto. Desde que mudamos, nos usamos no más hielo, no more ice touch, nosotros percebimos que el corazón se recupera muy bien. No todos nuestros trasplantes, todos nuestros receptores, nos hacemos en normotermia. Y nosotros acreditamos que el corazón que se aquece de manera lenta y gradual, tienes una buena recuperación, como he mostrado en vídeo. Y gostaria de compartilhar con los otros colegas o que piensan o que achan de esta situación.
Doctor Mariano Brancic, doctor Alejandro Bertolotti.
Dale, Alejandro, tu turno.
Bueno, muchas gracias, doctor Honorato, por su presentación. Excelentes datos, excelentes resultados y muy buena la estrategia para incrementar los trasplantes que han utilizado en base a pensarlo como un equipo de trasplante con gente dedicada y además con las estrategias que ustedes han cambiado en la técnica de la preservación y del manejo intraoperatorio y postoperatorio. Así que felicitaciones. Para nosotros es llamativo el hecho de que no usaran inotrópicos a la salida, habla claramente de que ustedes están muy conformes con la preservación. ¿Esto usted cree que tiene que ver específicamente con la preservación o también tiene que ver con el manejo previo del receptor?
Nosotros achamos, creemos que es o manejo de la preservación. Un gran impacto, la presencia de no más hielo. Esto fue muy importante. No, en pasado, nosotros usábamos hielo y yo he aprendido la preservación con hielo. Mas hielo no es uniforme, no es 100% perfecto. Usted puede poner una piedra de hielo en una situación que protege apenas aquella parte del corazón. Al contrario de la solución salina, que es helada y que protege el corazón de una manera uniforme, total. No ponemos hielo no transporte, apenas la solución de custodio. Só esto. Y nos creemos que esto es muy importante para proteger las coronarias, para no haber daño en ninguna arteria coronaria más superficial, que puede haber daño cuando se encosta el hielo, una piedra de hielo, y es muy, muy catastrófico cuando esto ocurre.
En el momento del implante, ¿ustedes realizan un segundo shot antes de empezar la isquemia caliente, antes de empezar el implante, o simplemente con un shot inicial del donante es suficiente?
Es una buena pregunta. Nosotros no hacemos más de un shot. Nosotros hacemos, como he dicho, 2 litros en el cadáver, retiramos el corazón de cadáver y en la situación del back table, nosotros hacemos 1 litro. No que se pase a esta situación, la situación de que con o corazón no back table, tenemos certeza absoluta de que la aorta está pinzada, is clamped, está pinzada, la situación de la presión está absolutamente controlada. Entonces, nosotros hacíamos de esta forma y no hacíamos más. Clamp and go. Nosotros hacíamos la preservación y tenemos algunos casos catastróficos que nós tenemos problemas de abertura de lo receptor que ha ultrapassado más de 6 horas. Y acredite usted, lo corazón late. The heart is beating. Nosotros tenemos una situación bastante catastrófica que nosotros perdemos la aeronave comercial. Estaba llegando en el aeropuerto con el corazón, con el órgano, y he visto la aeronave manobrando y decolando. Y esta situación era absolutamente desesperadora. Estaba en comienzo de las experiencias y nosotros no sabíamos cómo proceder de aquella forma. Y no había nada que podíamos hacer a no ser esperar otro avión. Esperamos 1 hora más e felizmente uma outra aeronave se dispôs a nos levar e fizemos o transplante com 6 horas. Nós outros todos fizemos a anastomose primeiro pela aorta e abrimos a pinça para a reperfusão. E qual não foi toda a situação quando todos nós começamos a chorar em campo cirúrgico? Nenhum de nossos cirurgianos conseguia terminar o transplante porque nós nos pusemos a chorar, porque o coração, the heart was beating. And the situation, e esta situação foi muito dramática para nós. Infelizmente, inafortunadamente, o paciente faleceu de infecção no 6º pós-operatório, porque o paciente, o receptor, ha entrado ao quirófano com uma infecção activa e estava febril ao momento da captação. Nós decidimos continuar o transplante e, infelizmente, ha perdido o receptor.
¿Puedo hacer una pregunta?
Claro, por supuesto.
Doctor Honorato, gracias por su presentación muy clara y excelentes resultados, como dijo Alejandro. Mi consulta es acerca de el eco que ustedes llevan, si eso les cambia o les ha cambiado la selección del donante. Para nosotros es difícil tener un ecocardiograma en muchos hospitales donde vamos a buscar los corazones porque la situación del país no es suficientemente buena como para que haya un ecocardiograma en cada lugar, así que muchas veces no hay ecocardiograma en el donante. y pocas veces hemos podido llevar uno nuestro. ¿Eso les cambia a ustedes o les ha cambiado a ustedes la selección de los donantes y han descartado donantes al llegar?
Muy buena pregunta. Gracias por la pregunta, doctor Mariano. Muchas gracias. Nosotros tenemos un biomédico que nos acompaña en todas las captaciones. ¿Y qué nosotros fizemos? Nos treinamos el biomédico. Nós capacitamos o biomédico que nos acompanha e que fica responsável pela infusão da proteção miocárdica. Então, esta pessoa não é doctor, não é uma pessoa cara, como custa doctor, é biomédico treinado por nosso serviço de ecocardiografia. Nós, cá em Brasil, temos a mesma situação, temos a mesma dificuldade. Al princípio, nós levávamos aparelho de ecocardiograma, pero este aparelho ha tornado obsoleto, ha ficado muito viejo, e os colegas cardiólogos não queriam mais fazer a avaliação do coração al cambio de la madrugada, sin ganar nenhum tostão. Então, ¿qué nos hacemos? ¿Qué nos hacemos? ¿Cómo resolver esta situação? Nós treinamos o biomédico e no local onde está o donante, nós perguntamos para a coordenação do hospital se tienes aparelho de eco. Olá, como estás? Tudo bem? Tienes aparelho de eco que puedo usarlo para fazer exame complementar que seria muito importante na avaliação deste coração? Sim, temos acá, pero não temos a pessoa que hace o exame. Mas eu tenho a pessoa que hace o exame. ¿Puedo fazê-lo? ¿Puedo fazê-lo? Sim, doutor, puede sim, por favor. Eu vou disponibilizar para você o ecocardiógrafo para que você faça esta análise. E isto muda sim, ha mudado significativamente. Nós aumentamos quase 30 a 35% da utilização de ecocardiografia, especialmente na população de donantes que são donantes limítrofes. Nós usamos donantes com parada cardiorrespiratória, nós usamos donantes com hipertrofia ventricular, nós nos sentimos muito confortáveis hoje para trabalhar, porque nós há criado uma rede. Ha criado uma rede de efetividade e isso se transmitiu para todo o sistema nacional. Uma vez que o sistema nacional ha visto que nós usamos, que há sucesso e que nós hacemos o que hacemos, todos agora trabalham a nosso favor para disponibilizar ecocardiograma. Trabalho, como dissemos acá, trabalho de formiguitas, trabalho constante, explicando para o sistema qual a importância, qual a necessidade e qual a relevância de ecocardiograma. Nós temos situações que não temos avaliação ideal, não temos nem uma radiografia de tórax, nem eletrocardiograma. Como eu vou fazer uma avaliação de coração se não tenho eletrocardiograma, se não tenho uma radiografia de tórax? Como é possível? Diga-me. Não há condição de fazer uma captação assim. Se eu mostro esses dados para os americanos ou os europeus, eles irão dizer certamente, você é muito louco para fazer captação sem ecocardiografia, sem avaliação adequada do coração, e como é possível ter esses resultados? Agora nós teremos uma equipe muito integrada, nossas enfermeiras são muito importantes, nós temos teléfonos de todas as principais organizações de procura de órgãos, que agora são nossas parceiras, que trabalham junto conosco em comunidade e trabalham vendo todos os nossos resultados. Nós convidamos as pessoas ao final do ano para compartilhar nossos resultados com toda essa cadeia. Eu creio que isto é uma boa oportunidade de trabalhar em conjunto para que todos atinjamos o mesmo objetivo.
Doctor Gondolesi, creo que tiene la mano levantada.
Gracias, doctor Norato. Si bien, como yo estaba en la sesión de abdomen, hay algunos temas que son comunes al tórax y al abdomen, y por eso me gustó mucho ver su presentación midiendo la temperatura del órgano, midiendo la temperatura de la solución. A mí me resulta, y creo que usted va a compartir esto, difícil de entender que al menos para el hígado, desde 1963, que se hizo el primer trasplante hasta ahora, seguimos haciendo las ablaciones como en esa época. Con la tecnología que hoy tenemos, no podemos medir cuánto tarda el hígado en enfriarse, si alcanzamos 4 grados en el parénquima. No sabemos cómo se va calentando la solución que creemos que mantiene el órgano a una temperatura estable cuando llega a la institución. Como usted bien dice, cuando le ponemos hielo alrededor, se hace escarcha en el agua y después el hígado tiene partes duras, partes blandas, y no termino de entender por qué tantos años después y con la tecnología disponible hoy en día no podemos tener un mejor proceso. Hay un solo estudio publicado recientemente que mostró que cuando uno empieza a lavar un órgano y la temperatura empieza a bajar, en la medida que baja, la osmolaridad de las soluciones de preservación aumenta. Y la que más aumenta es la de el Wisconsin. Por eso Richard Mangus decía que alguien dijo una vez que los Rolling Stones usaron HTK y por eso hicieron el disco Sticky Fingers, porque realmente te deja los dedos pegoteados. Y esto ocurre cada vez peor en la medida que la temperatura baja. El HTK, por el contrario, es mucho mejor que el Wisconsin en ese sentido, o sea, la osmolaridad no aumenta tanto cuando la temperatura baja. Creo que hay mucho todavía que trabajar en optimizar la preservación estática, pero por eso le preguntaba, ¿qué piensa usted de esto? Y si están trabajando en algo que permita hoy optimizar esto, porque es fácil echar la culpa solamente a la solución de preservación, pero hay tantas variables como el donante, la forma en que se enfrían los órganos, etc. Ese es un poco un comentario que creo que sirve a todos los órganos. Gracias por su presentación.
Gracias, Gabriel. Eu concordo com você completamente, Gabriel. Eu penso que nós temos muito que andar neste caminho. Não é possível que nós hacemos a preservação desde a primeira vez, desde hasta 50 anos. Eu penso que estas máquinas novas que fazem uma preservação dinâmica, que usam a solução de uma forma dinâmica, puede proteger el órgano de una forma muy más completa, muy más segura y efectiva. Por supuesto, sería necesario, sería interesantísimo que nosotros tuviésemos una medida de la temperatura de los septo interventricular en caso de corazón. Pero no es tan fácil hacerlo y puedo dañar lo propio órgano. Pero yo siempre repito para mis residentes, yo siempre repito, tienes que tomar cuidado con la solución de preservación. La solución de preservación, yo digo que es la alma del trasplante. La captación es la alma del trasplante. Por supuesto, es muy importante la técnica de implante. Nosotros hacíamos una técnica muy patronizada. Nosotros no mudamos, hacíamos un implante con 1 hora, 50 minutos de asistencia cardiopulmonar, de cardiopulmonar bypass. Nuestros tiempos son tiempos bajos, porque es siempre lo mismo time que performance, siempre da mesma forma, pero la preservación es la alma do trasplante. Entonces, si usted hace una buena preservación, proteja la solución, no la deje expuesta a la temperatura, no la deje expuesta a luz porque es termolábil y es fotosensible, proteja que elas le protegerá. Entonces, este principio aplicado a la protección, aplicado también a no ice touch, protección sin hielo, y la asociación de la normotermia, que yo pienso que es muy importante, lo reaquecimiento lento y gradual del órgano, al contrario de encharcarlo con sangre frío nuevamente, porque estás aqueciendo. De un minuto para otro, gana una ducha de agua fría, el corazón fica maluco, no comprende qué haces. pero nosotros aquecemos lenta y progresivamente. Y de una manera muy fisiológica, abrimos a pinça para que receba um sangue caliente, um sangue oxigenado, e o resultado é o que eu he visto, é o que eu he demonstrado para vocês. Eu penso que estes são os pilares, mas não é científico, né? Não há um trabalho científico que nós podemos concluir nesse sentido. É uma apresentação de ordem prática que eu estou aqui trazendo para vocês, colegas.
Bien, muchas gracias, doctor Honorato. No sé si el panel le queda alguna pregunta, si hay alguna a través de YouTube. Gabriel, Pablo.
No hay ninguna pregunta en YouTube. No sé si el doctor Brancic tiene alguna pregunta.
Sí, una. Escuché que el doctor Honorato nos dijo que aceptaba corazones con diferentes condiciones que normalmente la mayoría de los grupos rechazan o rechazamos, paro cardíaco, hipertrofia y demás. Nosotros todavía somos muy cuidadosos en aceptar corazones que tienen muchos inotrópicos, hablo del donante. ¿Cómo ve usted esta situación? ¿Cuánta droga en el donante es la que acepta normalmente o si eso no lo tiene sin cuidado?
Sí, nosotros tenemos bastante cuidado con esto también. Acima de medio micrograma kilo minuto de noradrenalina, nosotros no gostamos mucho. Nosotros preferimos trabajar con una cantidad menor de drogas, pero nem sempre é possível termos esto. Nestes cenários, nestas situações, nosotros solicitamos a realização do ecocardiograma. E quando temos dúvida, quando temos alguma questão que temos que resolver, este donante é para o enfermo que está com ECMO, o ECMO está com 17 dias de assistência, temos que tomar uma decisão, o que nós fazemos? Fazemos ecocardiograma em local de donante. Se a condição ecocardiográfica, o momento da captação é boa, nós utilizamos. E tenemos una estrategia un poquito más agresiva porque es, como he dicho, nuestra fila es dramática. Nosotros tenemos 88% de pacientes en carácter prioritario. Nosotros tenemos 62% dos pacientes con balón intraaórtico y con inotrópicos, y o que es inaceptable, es una carga muy grande para nuestro hospital. Hasta o momento, eu tenho 15 pacientes em caráter prioritário máximo. Em Brasil, caráter prioritário nacional. Por supuesto, puedo fazer uma captação acá em São Paulo, como puedo hacerla em todos os estados vizinhos, como he mostrado, pero nosotros somos um pouquito mais, como he dicho, um pouquito mais tolerantes com esta situação.
Bien, creo que si no hay ninguna otra pregunta y en hora del tiempo, Gabriel, podríamos ir cerrando esta charla. Doctor Honorato, felicitaciones, muchas gracias por su participación, impresionante los datos y la forma en la que los presentó. Gracias por haber estado.
Muchas gracias. Yo quiero aquí hacer un convite a todos los colegas de Argentina. Si quieres vir acá, nos visitar, quieren ver nossa rotina. Eu penso que temos muita experiência para cambiar, com vocês também em Argentina. Estou aberto a recebê-los acá, será um grande prazer, um grande honor tê-los acá para conhecer nosso serviço, compartilhar experiências, e eu os convido hasta agora. E los felicito mais uma vez por essa iniciativa de donantes em asistolia. Esto será muy importante acá en Brasil, porque en Brasil la donación ela es consentida. Entonces, nos tenemos que mudar la legislación acá en Brasil para podermos trabajar con ese tipo de donante. En este momento es prohibido, la legislación nos no permite para esto. Buena suerte, un placer y un abrazo a todos ustedes.
Doctor Honorato, Gonzalo, Richard, son los invitados extranjeros que han hecho engrandecido estas jornadas. Quiero agradecerles por la participación, la valiosa contribución. Coincido con Ronaldo en el hecho de que la iniciativa justamente de hacer esto como donación a la asistolia era para abrir la discusión Nuestra ley argentina pues ya lo ha abierto, pero no lo ha legislado, regulado, y estamos trabajando en ese camino. No se puede abordar el donante en las historias sin tener una ley que proteja a todos los médicos, a los equipos de trasplante, que haga sentir segura a la familia en la transmisión de la información y los cuidados al final de la vida. Así que claramente será un placer incluso compartir, como usted bien dice, Ronaldo, nuestra experiencia para lograr que los países de la región puedan seguir el camino de la legislación, imitar lo que uno puede hacer, porque creo que así hay que hacerlo, hay que, digamos, repetir experiencias y no como estamos tratando nosotros de aprender de la gente de Europa y de Estados Unidos. Así que a todos los que han participado en las jornadas, muchísimas gracias. Les pedimos nuevamente las disculpas por el primer día que tuvimos que cancelarla. Fue algo que nos sorprendió y nos dejó muy mal a todos. Sinceras disculpas en nombre del comité organizador de la Universidad Favaloro. Ha sido un placer poder tenerlos y que los hayan seguido acompañando a pesar de tener que mudar la fecha. Y bueno, nada, los invitaremos nuevamente a próximas reuniones y a las órdenes de todos. Muchas gracias a todos los participantes. Un abrazo grande y buen fin de semana.
Un abrazo,
Gracias.
muchas gracias.